this is really one of those occasions where I wish I had known what the preceding lecturer was going to talk about, because I would have addressed my talk to you with slightly different slides, because there's so much crossover between what we are talking, yet so much difference. So, for example, I can tell you that we are testing routinely our IVF patients when they come in for inflammatory markers, and if they have an elevated C-reactive protein, the IVF chances after correction for all confounding factors are 40% lower. And if they have abnormally elevated IL-6, their miscarriage rates are 30% higher. So inflammation is a huge overlooked issue in our specialty. Anyway, conflict statement in the US, we have to do that. I will be talking a little bit about androgens and their effects on ovaries, and I have some commercial conflicts there, so please take that into consideration. I'm going to start going a little bit more into the clinical approach than the preceding speakers have presented to you, though I want to make the point that was made before, that I think if there is one primary message in IVF today to be given, then it is, in my opinion, individualization of care, individualization of cycle management. And as I hope I will be able to demonstrate to you in those 30 minutes, not only in stimulation, but this individualization, at least at our center today, carries into the laboratory for all the reasons you have heard today. Even our embryologists don't do the same embryology on every patient. I will be talking to you also about preparing the ovaries, and this again fits into what you have heard earlier in this morning. Our eggs and embryos, which is the principal stuff we are dealing with, they are the end product of 3 to 4 months of follicle maturation, as you have heard so exquisitely demonstrated to you. It seems a little bit naive to think that in the last 2 weeks of this long journey that follicles and the oocytes in them make, that in the last 2 weeks we really still have a lot of power to make changes. So much is already predetermined much earlier in that journey. And I think that's another important message that I want to get across here. Stimulation of ovaries is obviously of importance, but when we stimulate, or when we stimulate ovaries, when we stimulate our patients, again, we are really only intervening in the last 2 weeks into the gonadotropin-dependent phase of that long journey. So I think we need to be modest in our expectations, what we can still achieve at that point. I will talk a little bit about the individualization of embryology, and I will conclude with what surprisingly can be achieved even in very poor prognosis patients today if this kind of an approach is followed. So you all know this picture. You know that women are born with all of their eggs, at least that is still the dogma. And that egg numbers decline until menopause, and that this is a process that is believed to take about 3 to 4 months. And what is important is that this process is not only one cycle. It is a continuous process. Recruitment out of resting stage of follicles happens all the time. And then after a while, follicles get arranged in waves, and that's why we have a monthly cycle. But all of this is not constant. Everything in this pattern changes with advancing female age. You have heard here wonderful explanations about the divergence of follicle cohorts within one cycle. I can tell you that this divergence radically increases as women get older, and especially increases if women are above age 44, 45, which in our center today is almost half of our patient population. It goes to such an extreme that you face exactly the problem that the preceding speaker addressed, that you have very frequently one or two larger follicles and many smaller follicles, and you have to make a decision where to go with your cycle. And in the old days, we used to sometimes give up on the big ones and try to preserve the smaller ones because there were more, and we had horrible results. And so nothing is constant, and what I'm trying to say to you here is that the one thing you cannot and should not believe that there is one way of doing it to every patient. Every patient really needs to be individualized primarily based on her age and based on her ovarian reserve. And while those two run in parallel, most of the time, they do not run in parallel, at least in 10% of patients. And then there are additional factors, like, for example, inflammation, that also require individualization. And if we find inflammatory markers in our patients, they automatically go on aspirin. And if they have significant inflammatory markers, they also go on Plaquenil. So, we kind of fell into treating older women more or less by accident, and I will tell you that story in more detail in a moment. But what gave us the biggest push into trying to improve outcomes in older women was our recognition roughly 15 years ago that androgens, which we for a long time up to that point believed were bad for female patients, actually are very important for normal follicular maturation. And what you see here are the early stages of the recruitment, the so-called small growing follicle stages. And you see in those slides that during those stages, in addition to FSH receptors, granulosa cells also develop increasing androgen receptors. And these androgen receptors have a function in the little corner on the right side. You see the feedback in granulosa cells between FSH and androgens. In other words, androgens at those early growing follicle stages are of critical importance in enhancing sensitivity of granulosa cells to FSH. And women who have low androgen levels, therefore, do not produce good numbers and good quality eggs. And this was first shown in animal models, and as I will show you in a second, has since also been shown, at least indirectly, in some clinical studies. Now, during those early stages, not only androgens are important, but this is also the stage where human growth hormone, or at least IGF-1, is active. It is the small growing follicle stages, and the reason why I am raising human growth hormone before going on in my discussion of androgens is that timing is of great importance. When we supplement patients with androgens, for whatever reason, the effect we are achieving is on small growing follicles. But those small growing follicles are still at least 6 to 8 weeks away from reaching the gonadotropin-dependent phase. Now, many people have started using androgens. Many people, some of you may be amongst them, are using human growth hormone in IVF cycles. But if you give patients androgens or human growth hormone only during the stimulation, you're really not achieving your goal, because the effects on the mature follicles are minimal. The effects of androgens and human growth hormones are really on small growing follicles, and those follicles still need time to reach sensitivity where they become available in IVF cycles. And so if you ever are thinking, or if you're already supplementing certain patient population with androgens, or if you give human growth hormone in order to enhance your stimulation protocols, you really should do that for at least 6 to 8 weeks before you take your patients into an IVF cycle. So human growth hormone, as I said, acts also primarily on small growing follicles, even though there was recently some data published which very interestingly show that human growth hormone apparently also has significant effects on endometrium and possibly on implantation. So what does all of this mean? And once again, in correlation with what you heard already this morning, we have spent 60 years of modern infertility care since gonadotropins entered practice in concentrating on the last 2 weeks of this journey that our follicles make over 3+ months. And what our experience with androgens has told us is, and with human growth hormone as well, that we really need to start thinking about a new paradigm of intervening earlier into follicle maturation processes. You heard before that the oocyte is basically pre-programmed for its life as an embryo. And most of that pre-programming, as you also heard, happens actually in later stages. But the early follicle maturation stages, during when follicles are in small growing stages, before small antral follicles, still have major importance for the ultimate outcome of your stimulation. And I think with androgens and human growth hormone, we are just at the beginning of intervening in those earlier stages. So our story with androgen supplementation started when a patient walked into my office at age 42 and asked to have her eggs frozen. And that was roughly 15 years ago. And we were not very favorably inclined, but we agreed to do 1 cycle, and that's it. And in that 1 cycle, we got 1 egg and 1 embryo. She came back and literally on her knees begged for a second chance. And we gave her a second chance. And she produced 3 eggs and 3 beautiful embryos. And then we couldn't refuse her anymore. And what you see here are subsequently a total of 9 consecutive cycles, almost months after months, or really months after months. This was quite a wealthy woman, a very intelligent lawyer and banker. And after the 6th cycle, she came one day into my office smiling and said, "Dr. Gleicher, I have to tell you a little secret." And as you can imagine, when you look at those egg and embryo numbers, we by that point were scratching our head what was going on with this patient. And the secret she told me about was that after our first cycle, she went to the literature and she found a few papers that suggested various remedies to improve egg numbers. But the only remedy that she could get her hands on without telling us was DHEA, because in the US, under some crazy law, it's considered a food supplement, so you can buy it without prescription. And since she could get it without telling us, that's what she started taking. And that's how the story started about our involvement with DHEA. And that's how the story started, and that I think, I'm convinced, led at least some of you in the room here to use androgens for supplementation. Now, we started studying DHA after this experience because after the 6th or 7th cycle, we literally had to step down the stimulation in this patient, because even though by that point she was already 43, she developed PCO-ish ovaries, and we were seriously worried to hyperstimulate her. And I have to say, at that point, we had no idea why all of this was happening, why DHA was working. And once we started reading up, once we started studying, a few things became clear. And I don't have the time to go into details, but in a few prospectively controlled studies, not randomized, case studies, we showed that DHA supplementation, and initially we did it simply for a period of 6 weeks. We since have become a little more sophisticated. Showed that it improves egg and embryo numbers, it improves egg and embryo quality. Spontaneous pregnancy rates while patients were on DHA and waiting to go into cycles were surprising. Improves IVF pregnancy rates, improves time to conception, and improves, obviously, cumulative pregnancy rates. These are some of those references. What you see here is what happens to AMH in younger and older patients, and under DHA supplementation up to 120 days, and you see that AMH increases, obviously more so in younger than in older patients. FSH does not increase, and there are various reasons that explains that. What this slide shows is a collaborative study between us and the Canadian group, which was one of the first groups that started using our DHA protocol once we published it. And one day I opened my emails, and I had this email from Ted Ryan in Toronto with a big attachment of all of their cases. And what you see here is an analysis of miscarriages for both of our groups after DHA use in comparison to US national IVF data. And I think it is quite apparent that patients who were supplemented with DHA, and those were obviously all patients with low ovarian reserve, after age 35 had a much lower and progressively lower miscarriage rate than the general IVF population in the US. And as you can see, the difference increased with age. And we were really stunned by these findings, and we concluded that the only potential explanation for such a big difference could be changes in aneuploidy rates. And so we looked at patients with low ovarian reserve who are known to have higher than normal aneuploidy rates in their embryos. And indeed, and this was still in the old PGS days with fish, we found significantly lower aneuploidy rates in patients who were supplemented with DHA than in controls. There were prospectively randomized studies of DHA, the first one by Weiser from Israel. It was the first prospectively randomized study, but up till today, there is not a single randomized study that had appropriate power on the subject. So all the data that is available is lower level of evidence. 17 DHA and 16 control patients obviously can never give you a significant outcome, even if the study claimed that it was significant. But there's convincing evidence for the importance of androgens in early follicle maturation stages. And the most convincing evidence that really made it clear for us what we were seeing clinically came from the laboratory of Erythro Sen, who initially developed a androgen receptor knockout mouse model where he could really demonstrate by either knocking out the androgen receptor on oocytes or on granulosa cells, what the effects are, at least in the mouse. And what you see here is a follow-up study after we started collaborating with him, where you see what happens to number of follicles in a mouse model under FSH stimulation, and what happens in that same mouse model if the FSH stimulation takes advantage of the synergy with androgen supplementation, in this case DHA, the number of oocytes greatly increased. And then if that androgen effect is blocked by flutamide, and you see how the number of eggs drop. And this group also very nicely and in detail demonstrated how the androgen work, and they work through the androgen receptor. On granulosa cell, there are hardly any effects if you knock out the androgen receptor on oocytes. So it is the granulosa cell that is the target, and androgens improve AMH expression. There is the synergism in improving sensitivity to FSH, and they improve, very importantly, follicular survival, and that's why you end up getting more follicles and better follicles. There are quite a number of additional animal models that have been published since, including large animal models like the study recently in human reproduction in the sheep, which basically literally reproduced in the sheep almost all the results which we have had reported before in humans. All the list of findings were replicated here in the sheep after DHA supplementation. Now, just as a little side note, what these slides show in the upper left corner is that whether a woman has low ovarian reserve due to age, or she has low ovarian reserve at young ages, what we call premature ovarian aging, in principle, practically every woman who has low ovarian reserve has also low androgens. And if you don't monitor your patient's androgens, I suggest you start looking at their testosterone levels. You will be surprised to find how many of them have extremely low testosterone levels, and therefore, in compensation, usually high sex hormone binding globulins. This study was also for us a first hint that there may be a connection between low androgen levels in those patients and adrenal function. And I don't have a lot of time to talk about that, maybe in the question and answer session, but we have now convincing evidence that adrenals and ovaries not only have a common embryological primordium, but they really represent an endocrine axis, and that adrenals, through their proportional androgen production, 50% of androgens in women come from the adrenals, have really an ability to control ovarian function. And what you see here is what happens to androgen levels after supplementation, and who does get pregnant in IVF and who doesn't. And when you look on the left side, total testosterone, right side, free testosterone, very similar results, but total testosterone shows it a little bit better. The white circles represent patients who did get pregnant, the dark circles, those that did not get pregnant. The first group is baseline levels of testosterone before DHA supplementation. The second group is the concomitant DHA levels after DHA supplementation before IVF cycles start. And you can see that actually the patients who got pregnant started with lower testosterone levels and reached higher testosterone levels. In other words, they had a bigger delta than the patients who did not conceive. So it is important to raise testosterone levels. I don't have time to go into stimulation of ovaries. I want to tell you, however, what not to do in patients who have poor ovarian reserve. You have to avoid everything that is suppressive to the ovaries. And for us, that means no long agonists. It means no antagonists. It means no birth control pills ahead of the cycle. And the reason is simple. And this is from another study we published a while back. After age, the number of eggs and embryos that a patient receives is the single most important predictor of pregnancy and live birth chances. You see this here. Those are almost straight lines. And these are all poor prognosis patients. So the more eggs and embryos you can get from these patients, the better their pregnancy chances will be. I mentioned to you that our individualization of care now also reaches into the embryology laboratory. And what do I mean by that? We used to have pretty good pregnancy rates up to age 43. But then after age 43, we saw a very steep decline. And we didn't understand why it didn't continue straight as it did up to age 43. And so we started a study, which was published 2 years ago, where we looked at the molecular biology of follicles in older women above age 43 and compared it to the molecular biology in younger women. And without going into too much detail, every single premature luteinization factor was elevated in older women above age 43. In other words, what the study showed us is that women at age 43, by the time we retrieved their oocytes, had practically all prematurely luteinized follicles. And so the question arose, what to do? And since we had no pharmacological solution to premature luteinization, we decided the only way to get around this is through earlier retrieval. Get the eggs out of the bed follicular environment before they are exposed to the negative effects of premature luteinization. And we arbitrarily chose a follicle size of 16 millimeters in women above age 43. And we published the study, and we were able to show that by doing that, yes, we got some more premature eggs, but in the end, we ended up with more embryos that we could transfer, and we almost doubled our clinical pregnancy rate. Since then, we have completed a follow-up study in women with premature ovarian decline, in other words, women with premature ovarian aging, and we found the same effect in those patients. And we also titrated follicle sizes, and we came to the conclusion that 16 to 18 millimeters was really the ideal size. If you went in younger women below 16 millimeters, pregnancy rates were just as poor as going to large follicle sizes. But over the last 2 years, we also at our centers are seeing more and more really older patients, and I'm talking about 45, 47, 48, 49, going through IVF with their own eggs. And what we learned since then in those patients is that in those patients above age 44, 45, we indeed have to go even earlier. And I mentioned briefly earlier this morning that one of our patients who was 2 months short of her 48th birthday when we transferred her, just delivered a baby, she was retrieved at lead follicle size 12 millimeters. And we got 3 mature eggs from her. 3 embryos were transferred, and she conceived and delivered. Now, this is not taking it yet into embryology per se, but I also mentioned that as a consequence, we're getting more premature eggs, obviously, as we go earlier and earlier. And we are seeing this dichotomy of getting atretic and immature eggs, and frequently nothing in between. And then the question arises, what to do? Well, I can tell you what we're doing right now, and I don't have final results yet, but the preliminary data is actually quite positive. We have changed our policy. We are no longer trying to go for the big follicles. But once we know that we are having a patient who has this problem, we are going even earlier in our next retrieval, knowing that we will basically get only immature follicles. And we retrieve her, as I said, sometimes at lead follicle size 12, 13, 14 millimeters. We don't strip the oocytes. We incubate them overnight. We strip them only in the morning and only fertilize them in the morning. And so far, it looks like we're getting more good eggs and good embryos. And I hope next year, if you invite me again, I will be able to give you some data on pregnancy outcomes as well. Let me close with what can be achieved. Those are 2015 rates. Our center's patient population is aging at an incredible rate. You can see that already in 2015, over half of our patients were above age 42. We in 2016 had the median age of 42.25 years or something like that. I am convinced that this year, 2017, we will close above age 43 because it's really incredible how many older patients we're getting to see. The pregnancy rates in older women are obviously very low, but they are not as low as they are advertised or claimed to be in our literature. You can see here that we are seeing women having babies in the mid-40s to almost age 48. Thank you very much.